Okay, this next lecture we're going to spend a few minutes on basic life support. The definition of basic life support is the preservation of life by the initial establishment and or maintenance of airway, breathing and circulation and related emergency care. This is from the Australian Resuscitation Council guidelines in 2006. This is the flowchart which is currently up to date as of December 2010 for basic life support, and we'll spend a little bit more time looking at this in the next few minutes. We start with dangers to yourself, dangers to any other rescuers, dangers to the victim or victims, and making sure that you keep people safe continuously. Checking for a response, sending for help, opening and assessing the airway, checking for breathing, starting chest compressions at a rate of 30 to 2, and attaching a defibrillator as soon as you can. Of course, basic life support really is about preserving physiological function rather than actually treating the patient. It's designed for everybody. It's designed for people in the street or people who work in supermarkets or airports. Therefore, it is meant to be simple, effective, and can be done with no equipment. Remember the doctor's ABC when you find a casualty, and don't forget to check for danger. Don't forget to send for help. Don't forget to ask for a defibrillator, and remember that there can be some differences between adults and children, and we'll discuss those later in the lecture. Basic life support is the most important bit of the life support course. This is the bit that you need to get correct because it underpins all other emergency care. The first few minutes of basic life support are the most critical in order to maintain the maximum physiological function for the patient. Let's look closer at danger. Remember, your own health and your own safety is the most important at the scene of an incident. Then look after the other helpers that may be attending, and then finally the victim or victims. And be aware of changing environments such as traffic or water or electricity. Things can change, so be vigilant constantly throughout the rescue that your exposure to danger may change. When we look at the response of the victim, we shout at them and we apply a tactile stimulus, typically a sternal rub. We don't shake the patient because at this point we're unsure if they may have a cervical spine injury, so shouting at the victim plus a sternal rub should be enough to assess their level of consciousness and their response. If they're unresponsive, the first thing we need to do is send for help. Remember that basic life support is not a definitive management, and so the patient is unlikely to wake up from basic life support. It's merely a maintenance of their physiological function until more definitive care arrives. So you need to send for help immediately. Okay? Be specific and use closed loop communication. So you point to somebody specifically and you say, you need to call me an ambulance. Do you know where we are? And ask them to return when they have performed that task, to close that loop of communication so you can be absolutely sure that an ambulance has been called and that it's on the way. Then you assess the airway. When you assess the airway, you need to of course make the airway patent, and we'll look at that in due course. And then you listen, look and feel for 10 seconds to see if there's any spontaneous breathing of the patient. Okay? We look inside the mouth to see if there's anything in the mouth, and then we can remove any obstruction from the mouth using the patient's own finger or a pen. And then we open the airway and listen for 10 seconds to see if there's any spontaneous respiration. Remember, when assessing the airway, there may be a C-spine injury, especially in trauma or car accidents, and this needs to be taken into consideration when opening the airway. Okay? So the first most basic form of the airway opening maneuver is the head tilt. Beware of the head tilt. It's good for opening the airway, but if you have a cervical spine injury, you could be causing more damage. There is the chin lift, which is effective but only a short-lived maneuver. And the one that most doctors favour is the jaw thrust, with your index fingers behind the angle of the mandible, shifting the jaw forwards, keeping the head in a neutral position and protecting the cervical spine. So perform a jaw thrust and then get down at the level of the patient and look, listen and feel for respiration for 10 seconds. In children, you need a more neutral airway position due to a larger epiglottis and a different airway anatomy. And we move on to breathing. When we look at breathing, we're listening and feeling for 10 seconds. Now, notice the lady is doing a head tilt and a chin lift in this instance, and she is looking down the line of the patient. She can feel breath on her cheek, she can hear breathing, and she can see breathing by looking at the patient. So look, listen, and feel for 10 seconds. If there's no spontaneous respiration, you need to start CPR, and you need to start it without delay. If the patient has no spontaneous breathing, they are unlikely to have a pulse. If they do have a pulse, they're not going to have one for very much longer. So start CPR immediately. Lower half of the sternum, pressing 1/3 of the depth of the chest, allowing complete recoil of the chest at 100 to 120 beats per minute. Okay? We want 30 compressions, and then you give the patient 2 breaths, 30 compressions, 2 breaths, and continue for as long as you can. Whilst you're doing CPR, you may be looking at other bystanders to see if they can help in the CPR, because it can be very tiring and you want to continue CPR with minimal interruptions. Chest compressions, you see on the left there, 2 hands interlocked, arms straight, shoulders over the patient, pressing 1/3 of the depth of the chest and allowing complete recoil. This allows for the myocardium to fill and then get squeezed with each compression. In the middle at the bottom, there is a child where 1 hand may be sufficient, and there's a toddler on the right where 2 fingers in the lower half of the sternum may be sufficient for chest compressions. Defibrillator. You need to ask for a defibrillator as early as you can and attach as soon as possible. When you're attaching the defibrillator, don't stop CPR. Get your assistant to apply the pads around you. Minimize your interruptions to CPR. Every time you stop CPR, the pressure in the myocardium drops, the pressure in the aortic root drops, and you have to commence CPR, and it's another few seconds before the pressure in the myocardium starts to build and you start to get a cardiac output once again. Now, there can be some differences between adults and children in arrests, and the most common one for children is that it's a primary hypoxic event. So the child loses oxygen and that causes them to collapse. This might be worth bearing in mind when it comes to children, and you can start with 2 rescue breaths, although if you start purely with chest compressions, that's okay. You want neutral airway positioning. Consider 1 hand or even just 2 fingers for smaller people, and it may be possible with a toddler that you may be able to perform CPR whilst you move the toddler to help, assuming there's no other danger. There are limitations to basic life support. As we've previously discussed, it's not a treatment, it's not intended to treat the patient, it's purely a maintenance of physiology until more definitive care arrives. If you do breaths, you're getting about 15 to 18% oxygen into the patient, and the most effective chest compressions give you 25% of a cardiac output. There's often delays in the CPR when the rescuer gets tired or there's attaching the defibrillator, and you need to keep these to a minimum. When the defibrillator arrives, you turn it on and listen to what it tells you, and you'll get a chance to practice this on the practical day, okay? And it's all you might have, so you just need to go as long as you can, as best you can, until definitive help arrives. Okay, thank you.